Hello, guys. Welcome to the Airway Academy Podcast. Dr. Sarah Johnson here, and my amazing co founder, Dr. Stephanie Joyce Sweeney. Today, we kind of wanted to delve into why is this important? Why do we want to treat at an early age, and what age do we want to treat at?
Yeah. So, in case you guys missed our first podcast, we are focusing really on airway dentistry. And I get a lot of questions from people. How is airway dentistry different from traditional orthodontics? And I think a big part of how airway dentistry differs is the time that we want to start treating. And so, with airway dentistry, we are not just trying to align and get beautiful teeth, although aesthetics come. We're really focusing on guiding growth so that we have best breathing and that our children are able to thrive. So there are a lot of benefits to catching this in childhood instead of waiting until we are adults. Not to say adults can't get treatment, and we're going to have a whole nother podcast sometime on adult treatment. But there are so many more benefits if we're able to catch this early in kids. So, Dr. Johnson, you were actually the one who originally taught this to me because, as many of you have heard, Dr. Johnson got into airway dentistry first, and she was really my guiding light into getting into this industry. And so she was the one who really taught me that traditional orthodontics are kind of waiting a little too long because traditionally we kind of waited till we were 12 years old or so to start doing ortho. And we now know by 12 years old, our head and neck is it 90% developed at that point in
About
time?
90 to 95% done in our growth. Whereas when we're at 4 years old, it's 50%. By 8 years old, 75 to 85%. So that's a huge difference in growth that we can guide these kids in growing while they're actively growing instead of forcing the growth to happen in ways that maybe aren't as comfortable for them.
There's a lot of uh, neural connections, right? So tell me about some of the behavioral effects that if there's a child who does have a dental airway issue, who is struggling to actually breathe as well as they should. And, this typically is just seen as maybe snoring or just even breathing with their mouth open. And you talked about your son in our last episode, and you could see signs when he was just a baby, right? So
Correct?
let's talk about the neurological connection and some of the behavioral aspects that we can see improvement on, or that maybe would be like red flags that they might have an airway issue.
Yeah. So believe it or not, our entire brain development is done by the age of 5 years old. 5. And our brain is completely dependent on oxygen. Not only that, but it is also completely dependent on us going into REM sleep. REM sleep is important for brain function, it is important for memory storage. It's important for so many. That is our restorative sleep. So, even if we have airway issues before the age of 5, we can still have impacts on the brain with sleep disordered breathing beyond the age of 5 years old. But it's really important to treat early because of that. Now, if our brain development is important by the age of 5, things that you guys can look for, really, even entering into infancy, right when you have your baby, there are signs and symptoms of this. Some common symptoms of tongue ties, at least, which can affect, as we know, the development of the oromaxillofacial structures. Colic. Colic is huge because if you have a baby that's not suctioning properly or latching properly, if they don't latch properly, they're going to catch air. When they catch air when they're feeding, it's going to come up one of two ways. It's either going to be here and we get reflux, or we get colicky babies. So, reflux, colic, improper latch, failure to thrive. If your child is not gaining weight, that means that they're not getting enough nutrition. That means they're not latching properly. Improper sleep, butt up sleeping. So many issues that you can see just during infancy that can be treated as an infant. Dr. Sweeney, you or Steph, you treat tongue tie releases. You do the tongue tie releases. Can you talk to
Mhm.
me a little bit about how you're screening these infants and kids for those tongue ties?
Yeah, so the most of the screening is usually based from the parents having struggles early on. So, unfortunately, like I'm not obviously a lactation specialist or a pediatrician or something where I'm getting to see every infant that's born in our area. So usually it's when the child is starting to have problems, and it usually majority is problems with latching. That's usually the main one. The other one, because I've educated my patients really good, is if they notice that their baby is sleeping with their mouth open. And that they're struggling when they try to close that little baby's mouth, that baby's mouth opens back up during sleep. Because I have educated my patients really well, they realize, oh my gosh, this is a red flag. Can you take a look at my baby? A lot of times, the parent, mother or father, one of them typically will have a tongue tie as well. So, especially if it was corrected when they were a child, or that maybe we've talked about it and identified it already in my practice, when the baby comes, I've already kind of coached them through like what to look for. Like, is the baby having problems latching? Is the baby having problems with digestion? Is the baby sleeping with their mouth open, or sleep sounds? Like sometimes people think it's cute, sounds like the baby's purring or something. Not cute, right? It might sound cute. The baby's adorable, and it does look cute when it's happening, but we know that's actually a sign of a problem, right? So I've kind of trained my parents that those are some red flags and reasons to bring the child in. We have a little thing that kind of looks like a pitchfork. It's like a little baby sized pitchfork, and it helps to lift the tongue so we can see what is going on underneath the tongue. Because unlike when we are screening for tongue ties in adults, obviously the baby cannot stick their tongue out at us. They cannot do monkey see, monkey do with various exercises. So we have to inspect ourselves. And so it is kind of difficult in babies to identify that tongue tie as easily. But that little baby pitchfork to help lift the tongue so we can investigate and see what's going on. And then if we do need to do tongue tie releases in infants, the earlier the better. So it is we just literally swaddle the baby up and we use the laser. There's no stitches, no bleeding. We don't use anesthetics. It's literally just real quick with the laser to cut that fascia. And a lot of times we see instantly that the baby starts to be able to latch and feed better. And we'll see better sleeping from the baby, less colicky. Very quickly, that baby will realize it is so much easier for them to live and survive. And that's how kind of babies are programmed to cry and whine and let somebody know, I'm struggling. I need help.
Yeah, and that's exactly what happened with my son. That's how I got into all of this is I knew something was wrong when it was constant colic, constant reflux, you know, everything that screamed a tongue tie, but not all providers really truly understand these tongue ties. The pediatricians back then, I think we're coming into an era and an age where this is becoming quite largely accepted that we have to screen for this. Like in Brazil and Australia, they screen for it immediately when the baby is born, but nobody would listen to me in the beginning. So, what do you have to say to parents that are struggling to find a provider that does recognize these symptoms? How do you know to look for somebody that knows what they're doing when it comes to assessing for tongue ties?
Yeah. So I would, honestly, a functional frenectomy. That is a question that I would ask is because you can look up online and find who does tongue tie releases, and you'll find that from a lot of different providers. And then the next question I'd ask is are they trained in functional frenectomies? Because the traditional training for a frenectomy, which the frenectomy is a fancy way of saying the tongue tie release, right? But the traditional way to do it was sedating patients. And not looking at function. So they were just literally looking for the fascia and trying to just cut strictly fascia. Functional frenectomies are different. And so I would ask the question, has your provider been trained in functional frenectomies? And I think that most offices that do that, their team would know what that term means. So that would be a question that I would call and ask. Um, I would also ask what type of device they're doing their tongue tie releases with. So if they say a laser diode, go run. Do not go to that practice. Um, I would really listen for that they're either using a CO2 laser or they're using an erbium and ND YAG laser. I would not go with any other type. Um, if they're strictly like they might be using that in conjunction with scissors, that's totally fine too. But if they don't have a laser, or if they're telling you that they're using a diode laser, I would run.
So now that we've talked about diagnosing tongue ties, Steph, can you tell me why it's important to address these things at an early age and what can happen if we don't address it at an early age? Because most providers will tell you, well, if you're not having problems with breastfeeding and you're not having problems with speech, you don't need to release a tongue tie. We now know that that is not true. So talk to me about the things that can occur that we will see in children when a tongue tie is not released. What effect does it have on the growth and development of our skull?
Yeah, so I will tell you, I am personally somebody who grew up in a very beauty focused world. I grew up as a kid doing modeling and things, and there's a lot of things that they would look for in models. That would be signs of beauty, right? And what I now understand as a provider is that those signs of beauty are actually signs of health. The growth of our maxilla is completely guided by our tongue positioning. So somebody who is tongue tied is not going to have the same growth pattern of their maxilla as somebody who's had that tongue tie released or did not have a tongue tie naturally. So some of those things, more prominent cheekbones, a broader smile, facial profile that is more correct, a straighter nose, not having a downturned nose, the cant of your eyes is actually affected. So, somebody who has kind of downturned eyes, versus somebody who has like fox eyes, that the fox eyes means that somebody's healthier. They have a better airway. They have a better maxilla that has expanded their face to create that aesthetic. So, the earlier that you catch a developmental issue, like guidance of someone's tongue for growth, the more of these aesthetic benefits that you're going to get. So everybody wants their child to be smart, beautiful, successful, all those things, right? And so we do all the things to try to make sure our child's going to grow up to that, like making sure they get proper nutrition and making sure they're going to the right schools. Some people spend a fortune on making sure their child goes to the right school, but you know what? Their brains aren't going to develop as well. They're not gonna be able to study as well in school. So we're gonna see behavioral issues like ADD, ADHD, and the aesthetic issues. We know somebody who had better facial development, well, they're going to be less likely to want plastic surgery. They're going to be less likely to be like, I need lip filler. All of these things with our facial aesthetics are actually guided by our maxilla. In fact, there's a really great book called The Beauty Potential. I don't know, Sarah, if you've ever heard of this book, but it's really awesome because it talks actually a lot about how the maxilla is probably the most important bone in our face when it comes to beauty.
Steph, you used to joke because I would send when we were both single in our lives, I would send you pictures of guys, right? And what was the first thing that you would say to me when I was sending you pictures like, "Hey, I want to introduce you to this guy." One of the things that you would tell me was
That he had downturned eyes, and I
he
didn't
had
wanna
to
I didn't wanna town talk to him.
and I'm like, "I don't get it." And I think it's so funny looking back now with everything that we know, those downturned eyes, like you said, that is a sign of health. You were talking about kids and ADHD. So, going into maxillary development, um, the maxilla, when we are forming our maxilla and we are developing and expanding our maxilla to create that big, beautiful smile and the eyes in the right position, our tongue guides that growth. The force of the tongue, if we are swallowing correctly, the force of the tongue being up and back and pressing out will put pressure on what's called the maxillary suture right here and expand that jaw. If we do not do that, that controls all of the airway structures that are in our face. So, our nose, the top of our palate is the base of our nose. The nose is where we need to primarily breathe out of. No, not primarily. The only place we really should be breathing out of. And if the palate stays high, we lose space. If we don't expand, we lose space. Our turbinates and our septum, they do not care. Most deviated septums come from a lack of space to grow. So they bend in on themselves. If our jaw does not grow forward, then the posterior airway won't develop. So airway dentistry, our portion of airway dentistry, so we work with teams, we work with ENTs, um, we work with myofunctional therapists. Our portion is to get that development going. I saw an interesting study recently that children who have sleep disordered breathing, and we're not just talking about sleep apnea, so sleep disordered breathing, where they're not getting proper oxygenation at night before the age of 5, are 10 times more likely to be at the bottom of their class as they get older. It affects our brain development so much. It affects our health so much. Our focus is the structural component. ENTs will focus on the soft tissue component, but it's so important. I read it's funny because I there was something that finally hit really home to me. There was another study. I was at a lecture for an ENT, and I talk to my patients about this all the time on how impactful this is, that our breathing through our nose is so important and the oxygenation. Dr. David McIntosh, an ENT out of Australia, I was at his lecture and I was listening to him talk, and I was kind of having this discussion with him on why do we want to take out adenoids and tonsils? Do we need to take out adenoids and tonsils? And I'm not saying that every child needs their adenoids and tonsils removed. That's for an ENT to diagnose. But he showed me a study that with children that have ADHD, and 85% of these children with ADHD, just having their adenoids and tonsils removed alone, 85% of those children no longer have the diagnosis of ADHD. So we have an option. We sit there and we say, we have this epidemic going on where children are being put on methamphetamines, or not methamphetamines, amphetamines. They're put in that would be really bad if they were on methamphetamines, but they're being put on amphetamines. It's dulling their personalities. It's making them skinny. Is there another option that's more holistic? Well, getting to the root cause. If they're not breathing well, their brains aren't functioning well, which then means that in order to stay awake during the day, us adults, we caffeinate ourselves to stay awake. Children, what do? Touch, 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 active, 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 speak, out, out, out. That's how their brains continue to function during the day when they're not fully recovered from sleep. So, all of these things, beauty, intelligence, performance in school, performance in their life, period, can be fully affected by this craniofacial growth. And I think that we as dentists, not just airway dentists, but every dentist, we see these patients more than any other doctor. We see them twice a year, sometimes 3 times a year. I think it's our responsibility to make sure that we are screening these kids for any issues. This is a time where we can sit down with those parents and say, "Hey, what are you seeing in your child? Do they have symptoms of ADHD, behavioral dysregulation? Are they have is not sleeping through the night? Are they bedwetting?" All of these things are so important to discuss, and I think we have a responsibility as providers to diagnose and find out those things, at an early age. Wouldn't you say, Steph?
Absolutely. And something that you brought up about adenoids and tonsils, talking about that. Um, I think that is something that is very well understood by pediatricians, right? They screen for that, and they absolutely do refer to ENTs when they see that tonsils are enlarged or a kid's been struggling with strep throat over and over and over again. Um, but what they don't really get to is the root cause of why does that kid keep getting strep throat over and over and over again. Why are those tonsils or adenoids so enlarged? And so I really do think that probably any child that is getting referred for adenoids and tonsils should probably also see an airway dentist, because
Absolutely.
it is definitely a red flag that is worth investigating. Because I don't know what the if there's any research that says what percentage of those children that get their tonsils taken out actually have delayed maxilla development, but I bet it's pretty high. Um, and a big reason too why a lot of those kids will have allergies or get just be the kids that are always getting sick. Mouth breathing. Like, our nose has cilia and our nose has nasal turbinates for a reason. These things help to filter our air and help to take all of those particulates, preventing them from getting into our bodies to cause the problems. But a child that's mostly mouth breathing, that child doesn't have that same layer of defense, and so their immune system,
Mhm.
it can't keep up. And then when they're not getting good sleep, when they're not if they're breathing through their mouth at night, that's activating their sympathetic nervous system, right?
Mhm.
And our
Mhm.
our parasympathetic nervous system is what guides immune recovery as well. So we've got this double whammy of, hey, we don't have all this filtration of the air that we're breathing because we're breathing it through our mouth instead of our nose. And then our immune system's not able to recover and repair like it should because mouth breathing doesn't activate the part of our immune system for recovery.
Yep. Absolutely. Mouth breathing also, when you're mouth breathing, you're actually putting off more carbon dioxide. So you're breathing out the CO2 more than when you would be through your nose. And what controls our breathing?
CO2.
CO2. CO2. So if we are putting off too much CO2 while we're breathing through our mouth, believe it or not, it tells our brain, stop breathing. So this could be many, I mean, there's so many reasons for kids to stop breathing through the night, but this is one of them. If they are mouth breathing, they are more prone to stop breathing through the night. Um, Kids with SIDS, they a couple years ago they did a study linking airway to SIDS, and it is 100% linked. Um,
That's
we need to
terrifying.
address it is extremely terrifying. These kids don't have the ability to wake themselves up, that reflex to wake themselves out out of an apnea episode until they get a little bit older. So if they're having these apnea episodes, then SIDS can happen. They can have an apnea event and that's it. So why wouldn't we be discussing these things at an early age, the minute a child is born, to help prevent those things from happening, to reduce the amount of SIDS that we're seeing, to reduce the amount of kids that are put on medication. No judgment to parents that do choose medication, but there are other options and that can give your kids a lifetime of good health. Because, Steph, what happens with adults, you treat a ton of adults. What happens in adults when this is not treated as a child?
Anxiety, depression, and eventually potentially sleep apnea. And then sleep apnea, you have an increased risk, 8 times increased risk of having a cardiac event. So, like cardiac arrhythmias, heart attack, stroke, all of that. There's a lot of really bad consequences that happen the longer that we're in this state. One other thing that I wanted to mention while we're talking about kids too, though, today is the athletic improvement. So we didn't really mention that, but we touched on the CO2 aspect, and I want to mention because our body and our brain is so sensitive to carbon dioxide, and so people with sleep disordered breathing, they tend to have a lower CO2 tolerance, and so that actually triggers you to want to breathe earlier. So this actually can be related to asthma as well. And kids who I am definitely would like to consider myself an athlete. Very much care about my athletic performance in a lot of the sports that I participate in. And actually, now that I know all that I know, I train for nasal breathing during that. And I'll tell you, when I first started learning about this, when I would go for a run, was a strict mouth breather. And you know what? Running sucked. I was not a good runner. It was a lot of effort, a lot of effort. I was in super high heart rate zones, and I was not fast. And as I've trained to improve my nasal breathing, and because it is something that you can work on too. So, there's some of it of are you physically able to, and is it postural or is it uh, structural? So for me, my mouth breathing was not structural, meaning I didn't have any problems with my nose. It functions just fine. So I had to just train that when I go and work out and things, I need to increase my CO2 tolerance and nasal breathe. And as I did that, you know what? My heart rate got lower and I was running faster, which is wild. But as you understand how our body functions, this makes perfect sense, right? And so
Absolutely.
that's another thing of, you know, hey, I think, like I said earlier, we all want our kids to be the most beautiful, the smartest. I should have thrown in there the most athletic. We want our kids to thrive. And that's why catching this early and treating early while we still can make a huge difference is so important, right?
Absolutely.
And
Absolutely.
I
So
think I was gonna ask, I think there was an article recently in the, like, Pediatric Journal of Pediatric Dentistry, recommending that kids actually have screening from an airway trained dentist, and if I'm not
mhm,
mistaken, is it by the age of 6, Sarah? Is that the
I believe
recommendation?
so. Yep, by the age of
Yeah.
6.
So that's something that just came out in the past year or so, which just shows how, yeah, it's huge. But that just shows how mainstream this has become, right? Because I think when we first started getting into this, it was a little bit on the fringe side of dentistry, right? And now the Journal of American Pediatric Dentistry. That's a huge thing to have them come out and say something like that. And so I think parents are also becoming more and more educated, and so they are searching out airway dentists. And what's really interesting is our pediatric residency programs are not all training our peds on this. They should, and I hope that soon they get caught up. But I think that these are some of the initial steps, and I'm really, really grateful that we have the opportunity to help get more doctors educated on this issue so that we can educate more parents and help more kids and adults decrease the anxiety that's in our society, decrease the amount, gosh, the amount of suicide attempts amongst teenagers today. It's terrible. Depression is rampant. And the other thing that's rampant is small mouths. And so we know there's a strong connection here. And so we know if we start guiding growth and getting expansion for all these children that were, bottle fed and not breastfed or maybe tongue tied, um, that we can make a huge impact out there.
Absolutely. Absolutely. I think that, we discussed, like you said, all of this was fringe. Like you said, it's been around since the 1970s, but it was kind of shoved down. And I remember when I started learning this stuff 10 years ago, I couldn't find any providers that really did this stuff. And now it's like every provider wants to learn it. And I love that something that I'm so passionate about that again, like you said, we were never taught this in dental school. We were not taught it. Most of us that got into this, it's because our children were in it, or we had friends who had children that were doing it. It was like, this is amazing. I want to learn about it. But now it's becoming highly accepted. I mean, Stanford University is doing incredible research with Dr. Audrey Yoon on the link between oral facial development and sleep disorder breathing with kids and adults. The proof is in the pudding now. It's no longer this thing where it's you guys are crazy. This is not proven science. It is proven science now that what we're doing helps. Is it the only thing that is going to help a child or adult? No, it's part of the puzzle piece. Working with a team of providers when it comes to an ENT, myofunctional therapist, speech language pathologist, all of these things can be part of the puzzle. We are part of the puzzle. And I really think that it's important that even if you are one of those doctors that's like, I don't know if I really want to treat this. I don't know if I want to see kids. I don't know if I want to treat it. Is it important to learn? Absolutely. So that we know how to screen and send to the proper providers that do know how to treat. We don't want to say, like, oh, yeah, that's not my realm. I'm not into it. I really want to focus on restorative dentistry. I like doing fillings. I like doing full mouth rehab. That's fine, but we still need to know how to notice these things because a lot of the things that we treat in dentistry are linked to airway. Periodontal disease can be linked to airway. Cavities can be linked to airway. Early premature loss of teeth or grinding linked to airway. wear on the teeth linked to airway. So it's something that we should know and have in our box of tools. Even if you're not going to treat the airway, you should understand it and how it's connected and when to refer.
And I'm so excited because, we've got a course coming up in Savannah, which is where I practice at. And I'm so excited. And I haven't shared this with you, Dr. Johnson, yet. But my endodontist is coming to our course. And
No
so
way.
obviously he's not going to treat airway, but he's going to see it and he's going to be able
Yes.
to talk to patients about it. And especially patients that are coming in for multiple root canals, that he keeps seeing back and back, like, you know, understanding the underlying issue that causes them for them, because it's for a lot of patients that need a root canal, it's not a cavity. A lot of times it's bruxism.
Trauma. Yeah.
Mhm.
How many
And
times have you seen patients come in with multiple root canals all across their teeth and they're still having pain? And
mhm,
we can't figure out why. Why are they killing
absolutely.
these teeth? Why are they cracking these teeth?
Mhm.
I
Yeah.
love that.
So,
Your endodontist
yeah,
is awesome.
he is, absolutely. But I think, just like you said, I mean, it is something that we should all be trained on, just like we all started off as a general dentist in dental school, right? All specialists that had to learn everything. Why? Because you might see it and you need to be able to tell somebody who to go to instead, right? And
Absolutely.
as a general dentist, you absolutely do not have to treat this, but you have to be able to identify it.
Yes.
Because that's the thing is, and it's so, I feel so bad sometimes when I get a new patient in my practice and I am the first one who ever told them that there was an issue.
This is
Nobody ever asked them about snoring before. Nobody ever looked to see if they were tongue tied. Um, and the worst part is seeing a teenager for the first time, and this happened in my practice today, who just got out of ortho, and it was extraction orthodontics. And she has already a receding profile. And mom actually came in and said, some of her friends have seen you for ortho and they have these really big, beautiful smiles. And my daughter is still really self conscious about her smile, even after having orthodontics. And they did extraction orthodontics and her mouth looks narrow and her smile doesn't look broad, doesn't fill it out. And mom couldn't really quite put her finger on it, but she was like, what's the difference? That's the difference, and that's, like, so heartbreaking to me to see, but also, like, if you don't understand what's going on, it's a lot harder to have that conversation.
it's interesting because that ties into why should we treat early? I get that question from parents all the time. I'm treating a 4-year-old or I'm treating a 6-year-old. Why do we want to treat this early? And orthodontists usually treat later. Why is this something that's now, and now I'm not saying all orthodontists. I have some amazing orthodontists here in Atlanta that treat early.
Oh,
So I don't want to put
absolutely, and we've
everybody in
got
that
we've
bucket.
got airway trained orthodontists.
Yes.
Unfortunately, it's not the majority.
Yeah. It's not the majority, but I think it will be. I think it will be eventually.
I think
Um,
eventually dental school is gonna teach this. I think it's that
yes.
critical that it's gonna be something that we eventually all are learning in dental school before we graduate. As much as we learn about how to do a filling, I think we're gonna learn about this because, um, as more and more studies come out and everybody's making these connections and the public demands it, right?
Yep.
Like,
Yep.
people want root cause treatment now.
Yep. And if you are treating at the age of 14 years old and there's a lack of space, it's much more difficult to make the space, to develop the structures. Treating at 4 years old when only 50% of their head and neck growth is done means that we can develop the structures to allow the teeth to come in where they need to so we can avoid extraction orthodontics. So we can avoid all these issues that we're going to have later on in life when teeth are not fitting in there. So I love that you brought that up because this is why we treat early. This is
Mhm.
absolutely why we treat early.
Yeah.
Yeah, and I'm excited that we are. I think our next course what is March 20th, Steph?
Yeah, March 20th and 21st in Savannah, and it's gonna be at the beautiful Alita Hotel. Really fun too. The St. Patrick's Day is huge in Savannah. It's the second biggest St. Patrick's Day parade in the country. So that's happening on March 17th. So come on down for the course, come a little early, go to the parade. and the whole thing can be a business expense. So we would love
Yeah.
to see you there. We do still have some opportunities. Um, and if that does not work for your schedule, do check us out, airway-academy.com. We do have future courses coming up later this year, whether it is adults or children expansion. We have courses on both. We'll probably be doing some sleep apnea appliances, maybe even some surgical courses. So keep track on our website to see about all of our future events. We do have some webinars as well. So we would love to see you at one of our future courses and help you be the provider in your area.
Awesome. Thank you guys for joining us today, and we will see you very soon.